All right, so for folks that are already on the Zoom meeting chat here and everyone that continues to join, this will be a recorded session for folks that either missed part of the beginning or can't make it all together, and it will be posted at the California ACC website within the next couple of weeks by our CEO, Leanna Collinge. So I would like to welcome you. We've had the California ACC Cardio-Oncology section has put on several webinars over the past year and a half during the pandemic, but we are starting up our inaugural Cardio-Oncology web rounds, and we're very proud to have UCLA Medical Center as the inaugural host site of this. We have an amazing couple of presentations as well as case-based presentations and an amazing panel, which I'll be introducing. The title for the webinar tonight is Heart on Fire, ICI, or immune checkpoint inhibitor therapy-related myocarditis in clinical presentations and panel discussion. So first, I'd like to introduce our first presenter, and it's Dr. Jacqueline Vuong. She is an internal medicine resident at UCLA Medical Center currently. She is already a very promising person within the field of immune checkpoint inhibitor therapy and cardio-oncology. Has a big publication with one of our panelists as well, Dr. Eric Yang, published in the Journal of American College of Cardiology, JACC, immune checkpoint inhibitor therapy and atherosclerosis, and a variety of other publications. So we're very lucky to have her as our initial presenter. We'll follow that by Dr. Celsa Diaz, who is finishing cardiology fellowship now and is one of the chief fellows at UCLA Medical Center, trained at Northwestern and came over to UCLA for fellowship training, and will be joining the South Bay UCLA group upon graduation. Moving on to our panelists, we have Dr. Eric Yang, who did medical school back at the University of Illinois, Chicago, and then went to Harbor UCLA for internal medicine residency and cardiology training, where he served as chief fellow. Joined UCLA on the faculty back in 2011, and has had a passion for education for a long time. Became the associate program director for the fellowship in 2013. As far as cardio-oncology goes, has had a passion for a long time. Actually founded the UCLA's cardio-oncology clinic and program back in 2016, and continues to direct the program. So very lucky to have him here. And our guest panelist is Dr. Deborah Wong from UCLA Hematology Oncology. Dr. Wong got her MD PhD from University of California, Irvine, and then proceeded to do her internal medicine residency training as well as a chief residency and hematology oncology fellowship, and served also as chief fellow at UCLA Medical Center. She is a prolific researcher and has a lot of publications in major journals, including in ICI-related therapy and some of the major clinical trials, including Keynote trial, Javelin trials, et cetera. So we're extremely thrilled to have Dr. Wong on our panel as well. So without further ado, again, thank you all for being here and everyone that's continuing to trickle in the audience. What we're going to have is Dr. Wong start our presentation. Please go ahead and feel free to put questions in the chat box, and I'll be able to help moderate the questions as we go a little bit later. So Dr. Vuong, if you'd like to share your screen.
I think I'm unable to share my screen under the current settings. Do you mind?
Sure, not a problem. 1 second.
Are you able to make her a co-host?
Yeah, it's trying to add that here. That button is not there right now. I apologize, everybody. Here we go. Okay, you should be able to do it now.
I think Dr. Bauer, it says that I can't share while you're sharing. So I think you'd have to stop sharing your screen first, and I should be
Sorry
able
about that.
to.
Go ahead.
No worries.
Stop share. Go ahead. All right, guys, we got it.
Excellent. Is everyone able to hear me and see my screen?
Yes.
Great. All right, so I'm going to just put it in screen sharing mode. Hi, everyone. As Dr. Bauer said, my name is Jacqueline Vong. I'm a third-year internal medicine resident at UCLA. Very excited to be applying into cardiology this year. And thank you for joining us for our cardio-oncology web rounds. I'm excited to present this case that I think really represents a lot of nuances and important considerations in the management of immune checkpoint inhibitor myocarditis. So without further ado, we'll go ahead and proceed with our presentation on fatal rebound, fulminant myocarditis following immune checkpoint inhibitor associated nephritis treatment in a renal transplant patient. So our case revolves around a 69-year-old male who has a history of end-stage renal disease from hypertensive nephropathy. He was on peritoneal dialysis for 10 years and then underwent a disease donor renal transplantation 16 months prior to his current presentation. 11 months after that, he developed worsening serum creatinine, and an ultrasound showed evidence of hydronephrosis. So a follow-up CT abdomen pelvis was done with evidence of a hilar mass in the transplanted kidney. He underwent renal biopsy that then showed a high-grade neuroendocrine tumor of the transplanted kidney that was metastatic to his periaortic lymph nodes and vertebrae, and notably developed worsening renal dysfunction and was started on hemodialysis again 4 months prior to his current presentation. Of note, One Legacy had contacted his kidney transplant team and had notified them that the counterpart allograft recipient also was diagnosed with the same neuroendocrine tumor around that same time point. The patient was then started on 5 cycles of etoposide cisplatin chemotherapy, and despite increases in the dose of his cisplatin therapy, he continued to exhibit tumor progression. And due to this tumor progression, the PD-1 inhibitor pembrolizumab was added on cycle 5, 2 months prior to his current presentation. 1 month later, the patient developed worsening gross hematuria and was hospitalized for this. A CT abdomen pelvis was done that showed a marked enlargement in the left lower quadrant transplanted kidney with associated fat stranding. Hematology oncology, as well as the transplant nephrology teams, were consulted with impression of immune checkpoint inhibitor nephritis, for which the patient was then started on 1 milligram per kilogram of high-dose prednisone, with then resolution of his hematuria within the first 1 to 2 weeks. And this was tapered over 4 weeks and ended 1 week prior to his current presentation. He, after this, underwent a 6th dose of etoposide cisplatin chemotherapy, but further doses of pembrolizumab were held. On admission here, he was then presented to an outside hospital with a sudden syncopal episode with no prodromal symptoms while en route to his usual dialysis session. He had associated left eyelid drooping and some blurred vision, and was noted to have generalized weakness that had developed gradually over the last few weeks, but acutely worsened 1 day prior to his current presentation. He was also reported to have associated fever, chills, and diaphoresis. His past medical history, as mentioned, significant for the end-stage renal disease with history of transplantation that's now with allograft failure and HD dependent 3 times weekly, hypertension, as well as history of a subsegmental pulmonary embolism 2 months prior to his presentation, and anticoagulation was held in the last month due to his recent gross hematuria. His medications actively at that time included alphazocin, benazepril, sevelamer, ferrous sulfate, and pantoprazole, with recently discontinued medications including Eliquis, his high-dose prednisone taper, as well as Bactrim PCP prophylaxis. His social history was significant for a remote smoking history of a 30-pack year history, and he was independent with his mobility and his ADLs. On physical examination, this was significant for tachycardia with a heart rate of 114, depressed respiratory drive with a respiratory rate of 5, and his blood pressure was hypotensive with 73/55. And he was on 2 liters nasal cannula, satting 95%. His physical examination was significant for being alert and oriented ×3, and despite being pale, had no other signs of acute distress. His cardiac examination was notable for a regular rhythm with tachycardic rate, no evidence of jugular venous distension. His lungs were clear to auscultation bilaterally, and he had no evidence of any lower extremity edema. His neurologic exam was notable for isolated left eye ptosis, but otherwise intact extraocular movements, and he had no other signs of focal neurologic deficits. His initial diagnostic workup and lab work are shown below, with notable leukocytosis to 25.5. Unfortunately, no differential was seen for further stratification. His hemoglobin was at his baseline of 7.9, and his BMP was notable for, in the setting of end-stage renal disease, hyponatremia to 126, as well as acidosis with a bicarbonate of 18. His other lab values were significant for a markedly elevated troponin I to 72 nanograms per milliliter, an elevated brain natriuretic peptide to 1223, as well as elevated AST and ALT to 347 and 122 respectively, an elevated CRP to 7.37, and elevated lactic acid to 3.4 millimoles per liter. His electrocardiogram is shown below. That is significant for ventricular tachycardia with an approximate rate just over 100 beats per minute, with ST elevations in the anterior leads from V1 through V4. His continued hospital course with this electrocardiogram then activated the cath lab. He was given aspirin 325 as well as started on a heparin drip. And his left heart catheterization was notable for normal coronary arteries, with an ejection fraction that was newly reduced to 30 to 35% by left ventriculography. His cath hemodynamic data are shown below, and with this, the patient developed worsening shock and was started on norepinephrine, broad-spectrum antibiotics, as well as stress dose steroids, and admitted to the outside hospital ICU for further management. A code blue was then called 4 hours later, and the patient was found to be in VT VFib arrest, for which he underwent multiple rounds of defibrillation, CPR, and received epinephrine, amiodarone, and lidocaine, with initial return of spontaneous circulation. 30 minutes later, he unfortunately developed pulseless electrical activity arrest and expired. His family elected to pursue autopsy, of which significant panels are shown here on the right-hand side. Most notable for CD68 as well as CD3 positivity on immunohistochemistry, suggestive of macrophage and T cell infiltration into the myocardium respectively. As seen in panels A, C, and F, the patient had infiltration of these inflammatory cells into his left ventricular myocardium, as well as into his sinoatrial node, but no evidence of infiltration into his atrioventricular node. As seen in panel E, there is evidence of myocardial staining that shows upregulation of programmed cell death receptor ligand 1, PDL1. And the rest of his autopsy report was significant for evidence of renal allograft rejection with an unknown chronicity, and that was not otherwise specified. And he had no residual tumor burden as a result, notably. So this case, I think, has several interesting discussion points to bring up. For the first of which will be the pathophysiology behind immune checkpoint inhibitor myocarditis. And while the exact mechanisms are still being elucidated fully, the current understanding is that there is evidence of T cell cross-recognition between tumor cells and cardiomyocytes that leads to the recruitment of T cells and other inflammatory cells, including macrophages, to the myocardium. Immune checkpoint inhibitors blocking CTLA4 and PD1 and PDL1 then enhances the ability for T cells to destroy both cardiomyocytes as well as tumor cells. And this upregulation of PDL1 in cardiomyocytes is thought to be reactionary and may be a sign of chronic T cell mediated immune activation. The epidemiologic and clinical features will be discussed below, with the current incidence reported at 0.04 to 1.14%, and this is increasingly being reported over time with improved recognition. The median time to onset is about 30 to 60 days after ICI initiation, but again, with improved recognition, the time point seems to be increasing, and later cases are currently being reported as well. The symptomatology includes chest pain, dyspnea, orthopnea, paroxysmal nocturnal dyspnea, palpitations, fatigue, lightheadedness, and syncope. And the clinical syndromes that these patients can present with can range from an acute coronary syndrome mimic to chronic to acute heart failure, as well as fulminant cardiogenic shock. As seen on the diagram here on the right-hand side, this is adapted from Dr. Palaskis et al. In the Journal of American Heart Association in 2020 that shows the range of symptoms ranging anywhere from asymptomatic with abnormal cardiac biomarkers and electrocardiogram, all the way to severe life-threatening disease with abnormalities that can be seen on echocardiogram and cardiac MRI as well. Additionally, there can be myocardial alterations and inflammation that cause high arrhythmogenicity, and this can be worsened with involvement of the SA node, such as in our patient, as well as evidence of AV node and bundle of His infiltration. So the common arrhythmias that are seen include ventricular tachycardia, atrial arrhythmias, including atrial fibrillation, complete heart block, and sudden cardiac death. Pericardial involvement can lead to pericarditis and associated pericardial effusions. And notably, ICI myocarditis often co-presents with ICI-related myositis and myasthenia gravis, presumably due to shared muscle antigens. The diagnosis of ICI myocarditis involves a range of diagnostic modalities and can be supported by serum biomarkers that show elevation in troponin assays, as well as brain natriuretic peptide, and EKGs showing arrhythmia abnormalities as well. Echocardiography can also help to show any evidence of reduced ejection fraction, although it's important to note that reduced ejection fraction is not seen in all patients who have ICI myocarditis. Other abnormalities that can be seen include regional wall motion abnormalities, abnormal strain, and diastolic parameters are also noted. Cardiac MRI is being increasingly used in the diagnosis of immune checkpoint inhibitor myocarditis and can show evidence of myocardial edema as well as late gadolinium enhancement suggestive of myocardial injury. The gold standard for diagnosis remains endomyocardial biopsy, but as seen in this white paper from Dr. Mark Banaka in Circulation in 2019, the diagnosis of ICI myocarditis can be kind of differentiated into definite, probable, and possible, utilizing the diagnostic modalities listed on the left-hand side, with definite myocarditis either requiring pathology or a diagnostic cardiac MRI in this setting in the appropriate clinical syndrome, or with an echocardiogram and a negative angiography in the appropriate clinical syndrome. It's also important to consider that there needs to be a high degree of clinical suspicion as well as expertise for diagnosis. And so transfer to specialized centers for access to diagnostic modalities such as cardiac MRI and endomyocardial biopsy, as well as for consideration of mechanical circulatory support should be also considered at non-academic, non-referral sites, such as where our patient was. And in addition, in kind of discussing the outcomes of these patients, it's important to note that despite the low incidence, there are markedly high mortality rates, estimated anywhere from 40 to 50%, 49.3% was noted in meta-analyses, and 55% mortality rates were noted in patients who only received steroids as part of their treatment, and 43% mortality rates were noted in patients who received another immunosuppressive agent. Risk factors for worst outcomes include combination immune checkpoint inhibitor use, as well as baseline elevated troponin levels, and the presence of advanced atrioventricular blocks. And due to the high initial mortality rates, as well as the increasing recognition of ICI myocarditis only in recent years, long-term outcome data are still lacking in this arena. Some case-specific points to bring up. I think this case is very unique in that we are presenting a case of rebound and immune checkpoint inhibitor myocarditis in a transplant patient that was recently treated for another immune-related adverse events. The first point to bring up is that this patient responded exceptionally to immune checkpoint inhibitor therapy with no residual tumor burden seen on autopsy after just one dose of pembrolizumab. To note, in the keynote study, keynote 158, upon which the initial approval for pembrolizumab in neuroendocrine tumors were done, there were 0 complete responders out of 107 patients receiving pembrolizumab. And in a meta-analysis of 636 neuroendocrine tumor patients, only 3 of them had complete response to collective immune checkpoint inhibitor agents. And there have been studies that show that there is an association between the rate of immune-related adverse events and a positive correlation with tumor response rates. Thus, careful surveillance and treatment of immune-related adverse events and exceptional ICI responders may be life-saving. In addition, clinicians must remain vigilant for signs of rebound immune checkpoint inhibitor toxicity in all organ systems when tapering steroids for any immune-related adverse event. The incidence of multi-organ immune-related adverse events in myocarditis vary, but are estimated to co-occur in 46 to 65%. The co-occurrence of specific immune-related adverse events in patients who have ICI myocarditis have been reported in the literature, with Dr. Avarit Guha and colleagues reporting an increased incidence of myositis in patients who have ICI myocarditis with an odds ratio of 25.5, encephalitis with an odds ratio of 2.94, and hepatitis with an odds ratio of 2.91. Dr. Saad Mahmood also saw an increased incidence of the following immune-related adverse events in patients who had ICI myocarditis, with hepatitis being statistically significant, and a trend towards statistical significance in patients with neurologic or dermatitis-related immune-related adverse events. And lastly, immune checkpoint inhibitor use in transplant patients warrants further study. The initial investigations of immune checkpoint inhibitors for FDA approval did not include transplant patients due to concern for rejection, and no current guidelines exist for the use of ICIs in this population. The evidence that we have to date are only from small case studies and from small retrospective studies with varied estimated rates of rejection from anywhere from 18 to 45%. And the safety and efficacy of ICIs in this transplant population are really needed to tailor improved surveillance strategies. And clinical trials for targeted immunotherapy and solid organ transplant patients are ongoing, which I believe Dr. Deborah Wong will kind of discuss the current clinical trials that are ongoing at UCLA as well. So the take-home points that we have are that immune checkpoint inhibitor myocarditis is a rare but increasingly recognized phenomenon with high mortality rates. The presentations can range from asymptomatic biomarker elevation to life-threatening cardiogenic shock and unstable arrhythmias. The diagnosis requires a high clinical suspicion, and referral should be considered to increase access to diagnostic modalities as well as advanced circulatory support. The coincidence of ICI myocarditis and other immune-related adverse events are frequent, and clinical vigilance is needed for ICI myocarditis in these patients. And additional data is also needed to evaluate the safety and the optimal delivery strategies of ICI in the transplant population. Here are my references. Thank you so much for your time, and I'm excited to hear from our panelists.
Sorry, had trouble unmuting myself. Thank you so much, Dr. Wong, for the amazing talk. What a great case presentation, and a lot of really great take-home points from this. As far as I had a few questions, we don't have yet any in the chat box. No, not yet. So anybody that has any thoughts or concerns, please put them in the chat box and we'll ask our panelists. But my thoughts were as far as, or my question, Dr. Wong in particular would be is, and Dr. Wong mentioned in her take-home points about the lack of data in using ICIs in the transplant population. What has your experience, been with it as far as, this is a case of renal transplantation, but both in renal transplantation or other transplant patient populations, is this a type of novel therapeutic for, more refractory cancers that are being increasingly used, or is there a lot of hesitation still there?
Yeah, that's a great question, and this a very impressive case presentation, Jacqueline. I think several points are pertinent in this case, in this patient with who's immunosuppressed from a renal transplant. It's long been known that patients who are immune suppressed, be it from underlying hematologic malignancies such as CLL or organ transplant patients, are at particularly high risk for very aggressive malignancies that are otherwise very easily managed. Classically, renal transplant patients develop terrible cutaneous squamous cell carcinomas. And really the treatment of choice is to decrease immune suppression as much as possible and switch out some of the immunosuppressants to things such as sirolimus, which has some anti-cancer activity. So I think that underscores the particularly aggressive nature of cancers in this immunosuppressed population. The conundrum is, of course, that we know that, because immunotherapies are specifically designed to release the brakes on the immune system, that when we treat with immune checkpoint inhibitors or other immunotherapies, we run the risk of hyperacute rejection. And so to date, only now after immunotherapies have been, standard of care for over a decade, are we now starting to really think about novel approaches to evaluate, how to interrogate the immune system as a cancer for transplant patients. And so I think generally speaking, we really reserve immune checkpoint inhibitors for the very, as kind of a much later treatment resort. I think in this particular case, the patient, standard of care for neuroendocrine tumors in the absence of immunosuppression would have been chemotherapy plus immunotherapy from the get-go. So the patient would have received cisplatin, etoposide, and pembrolizumab from the very beginning. Here, it sounds that, the patient started on platinum doublet chemotherapy, and then only at the time of progression was the pembrolizumab added. And so I think generally we're all very, very reluctant to use immune checkpoint inhibitors in this patient population. And I will say that for renal transplant patients, particularly in this patient, perhaps it was felt that since the patient had already, the graft was not functioning because of the cancer itself, perhaps, and the fact that, with kidney transplant patients, we have dialysis to fall back on, that the stakes were a little bit lower in terms of using an immune checkpoint inhibitor. Certainly, if we're talking about other solid organ transplants like lung or heart, or liver, we don't necessarily have that backup option.
That's great insight. I really appreciate that. As far as we'll go to Dr. Yang. As far as the presentation, it looked like with kind of a slow VT and then later developing the cardiogenic shock. What other things outside of what was done for the patient? Any other thoughts about what could else have been done for this patient, or not really at this point?
Yeah, I think this was such a fascinating but also sad case on so many levels, because as Jacqueline did a great job of sort of highlighting the really multiple unique facets of this case, this gentleman had the horrible luck of inheriting a malignancy, an undiagnosed malignancy from a donor, and then required a more high-risk treatment, and interestingly, presumably experienced, not so much rejection, but IRAE or immune-related adverse event. And this is something we have never seen before, which is not much of my understanding described in the literature. Upon weaning off immunosuppression from another IRAE, suddenly gets full-blown, myocarditis. And for all the cases we've seen, I think immune checkpoint inhibitor myocarditis is a disease state that continuously, frankly, humbles us. It continually challenges what we think is the right thing to do, and we still, frankly, just do not have an understanding of really sort of the trajectories of someone's altered immune system. And I'll defer to Deb on this too, but based on autopsy, it sounds like he might have fit the definition of maybe a super responder in a way, because they couldn't find any more cancer. So in some ways, the cancer saved him, yet, the treatment saved, but also unfortunately, was responsible for his demise. And I think, Jacqueline touched upon a lot of what we think we know about the onset of these symptoms. And I think a challenge of immune checkpoint inhibitor myocarditis is it can present in a whole spectrum of, ways, because patients sometimes present with a cardiac issue as their first complaint, but a lot of times they just come in with a bevy of other non-specific toxicities. And, maybe they could come in with diarrhea or colitis or hepatitis or, skin issues. And then someone checks an ECG because they have some non-specific dyspnea or dizziness, and lo and behold, then something is there. So we don't really know kind of where we're catching people in the whole spectrum of myocarditis. And with this person, this is a pretty obvious fulminant cardiogenic shock case. And I think usually with all the knowledge we know from our registry data, that unfortunately at this point, the mortality is probably pretty high, and they did one step, and, unfortunately it was not under differential. And I think the question is, where we throw in more heavy immunosuppressive agents, which I know Celso will talk about sooner, up front, would that have been potentially something that could turn the course for him? Could mechanical circulatory support have helped him, right? And I think this is a question that is very tricky and difficult, because cancer patients are at a whole spectrum of cancer stages when they come in presenting like this. And it's one thing to be in remission or responding versus someone who is stage 4, and this is sort of a last-ditch line effort to treat. And how aggressive do you go with these patients in regards to inotropic and mechanical circular support is a very difficult question that you have to weigh. And sometimes you don't have a lot of time to weigh it, or to make that decision. And he unfortunately, I think, presented at a hospital that was not familiar with his history. And I think that was also what made it, very difficult. And I think they did what most hospitals would have done. But based on how he presented, though, this was obviously a very, very sick sort of advanced stage of myocarditis when presented. And I think another very important point about how he presented is the signs of myasthenia gravis. Of course, the patient unfortunately passed before we could really work that up. But when we get these cases, it's important to understand that myocarditis rarely acts in isolation. It's usually other organ systems are involved. And for the first time in my career, I'm asking fellows and residents to ask them if they have double vision. I've not done that since I was a medical student, but like myasthenia gravis is a really known big culprit, or other things like hepatitis and colitis come a lot with these symptoms. So, if an isolated troponin by itself has nothing else, it's probably less likely to be an issue, but you have other, organ systems involved, and my red flag goes up. So this is an unfortunate case, but a really classic teaching point of a lot of things that, that show in a very fulminant example of immune checkpoint inhibitor myocarditis, but even more of the twist of, presenting in a transplant patient, which I know is controversial. And I know that there is very early data kind of testing these and how to kind of alter your immunosuppressive regimen to treat them. But to answer your question in short run, Brenton, yeah, I don't frankly think much more could have been done other than maybe escalating mechanical circular support. And even then, I don't think that might have been able to save this poor gentleman.
Well, I wonder though if earlier, like a higher clinical suspicion earlier on, right? I think the challenge is all advanced cancer patients, transplant patients have some degree of fatigue. They're on so many different medications that cause side effects. Fatigue is seen just as is the most common side effect of these immune checkpoint inhibitors. But fatigue, I think, we think about hypothyroidism or some of the other more common adverse events. And so certainly myocarditis can present, cardiac AEs can present as fatigue as well. But I wonder if maybe earlier on in the setting where, patient is clearly, having, autoimmune or immune related AEs, if there's an opportunity there to develop better, clinical pathways or workflows to at least help us to be more mindful about this very rare but diagnosis.
Yeah, I totally agree. I mean, I think it's always, again, weighing sort of the balance of a drug that's obviously very important. It's a big game changer that sometimes the only, the option that, or first line that is shown to be very effective in a lot of malignancies now. But, like you said, a lot of treatments, frankly, just make people tired. And also I know cancer patients don't want to keep going to the hospital for concerns or issues, and I know sometimes they try to sit it out unless it's like really problematic because of all the complications they can get. Personally, for me, when I counsel a patient, I always emphasize up front, this is super rare, but as a cardiologist, this is my bias. So I'm just going to tell you that, if you happen to feel that, if you start to have any cardiac, chest pain, shortness of breath, unusual signs after these drugs with sort of neurologic, symptoms or dizziness or vision changes, or you start noticing your blood pressure is very low or your heart rate is like fluttering or very fast or very slow, then you should probably get that checked out right away. It's obviously very nonspecific, right? I mean, anybody could feel short of breath for a variety of reasons getting cancer treatments, but I think it's a very, very, more often than not, I would say, at least in our experience, patients have been kind of more symptomatic than they've let on for a while. And so we catch them at different stages, but they tend to catch them later because something made them finally tip over the point where they, were just so either dizzy or so so disabled by whatever was, holding them back, like a heart rate of 30, for instance, that would finally get them, to seek medical attention. But it's a very tricky, I think it's very difficult with all the other things that they go through. And I've yet to kind of, it's hard for me. I have yet to kind of know what's the right pathway to go about it, because it is very tough to sometimes to tease out. So
that's both a lot of great advice and insights. We have one question from the audience, but I'm going to hold it just until the end so that Dr. Celso Diaz can get his allotment of time to get through his entire presentation. So go ahead and share your screen, Celso, and we'll go from there.
Are you able to see the screen okay? Perfect. So thanks again, Dr. Bauer. As was mentioned, I'm Celso. I'm one of the cardiology fellows over at UCLA, and we'll get started with this case presentation. So in terms of the objectives of this portion of the talk, we'll kind of walk through another case of ICI-associated myocarditis with a different presentation. And then afterwards, I'll kind of talk generally about the management of myocarditis in these patients, specifically talking about the role of steroids and some of the data behind it, and then some of the second-line immunosuppressants that should be considered in those that present much sicker or informed myocarditis. So for our patient, this is a 77-year-old gentleman. He has a history of hypertension and cholangiocarcinoma with mets to his liver and abdominal lymph nodes, who is currently on FOLFOX and nivolumab, who was sent to the ED for worsening fatigue and shortness of breath. The patient stated that his symptoms started about 1 week prior to his presentation. He endorsed both blurry vision and double vision, some muscle cramps that primarily affected his lower extremities, fatigue, and then shortness of breath that was particularly worse when he was laying flat. He also noticed that one of his eyelids was more droopy than the other and that his symptoms tended to be worse by the end of the day. He saw his primary care provider at the onset of these symptoms and was prescribed antibiotics for a possible sinus infection, and was advised to follow up with optometry for his vision changes that he was endorsing. Notably, his heart rate was 48 beats per minute at this visit, but that was kind of left alone at that time. His symptoms continued to worsen over the next week, and then he saw his oncologist after that. And at that time, he was still Brady to the 40s, and his exam was notable for some new lower extremity edema. They got an outpatient X-ray, chest X-ray that showed worsening bilateral pleural effusions, and at that point, they thought it was best to just send them to the ED for further evaluation. So in terms of his cancer history, he was first diagnosed with cholangiocarcinoma about 7 months prior to his initial presentation here. And at that time, he was admitted for biliary obstruction requiring a biliary drain. He was then started on FOLFOX about a month after that admission. And then he received his first dose of nivolumab with cycle 7 of FOLFOX about 2 months prior to his admission. He then received a second dose of nivolumab about a month prior to his admission with us, and that was with cycle 9 of FOLFOX. And then he was due this week that he was admitted for his cycle 10, as well as his third dose of nivolumab, but it was held given the concern for infection both in the sinuses, and there was also some redness around his port at that time that they were concerned about maybe a skin infection as well. In terms of his past medical history, I kind of touched on some of the pertinent things, but other things to know is that he has this history of a remote MI in 2001 at an outside facility. Reportedly, he had a left heart cath at that time that showed no obstructive disease, so there was no intervention done. He has hypertension, hyperlipidemia, he's diabetic, and then the cholangiocarcinoma, as I mentioned. No known allergies. His medications are listed here and include FOLFOX as well as nivolumab every 2 weeks. Allopurinol, amlodipine. He was on antibiotics for his sinus and skin infection, aspirin, pantoprazole, trazodone, and then some Ambien as needed to help him sleep. And then otherwise, he didn't endorse using any substances at this time. His initial vitals on arrival to the ED were notable for a heart rate in the low 50s. Blood pressure was 162/77, and he was sitting in the high 90s on room air. His exam is listed here, the pertinent things being that he was bradycardic with an elevated JVP. His lungs had diffuse crackles bilaterally. He also had 2+ lower extremity edema. And then his neuro exam, he had right eye ptosis. He had limited abduction of both of his eyes. And then when neuro saw him, they felt that he had deltoid fatigue with resistance on their exam. This was his initial ECG on arriving to the ED. As you can see here, he's in complete heart block with a ventricular escape rhythm at a rate of about 40 beats per minute. And you're able to see the non-conductive P waves more so in V1 kind of marching out there independently of the QRS. And then his QRS morphology is also consistent with the right bundle branch block and the left posterior fascicular block as well. And this is all new compared to an ECG that was done probably a couple of years prior at that different facility. These were some of his labs coming in. The pertinent things are highlighted in red here. He had an initial troponin I of 2.4 that increased to a peak of 3.2. BMP was up at 195. CK was 3,720, and then ZSR and CRP were also mildly elevated. And then CA99 here was normal at 42. Other things to note were that his creatinine was mildly elevated at 1.4, although we didn't have a baseline at this time. Platelets were a little low at 80. AST was up, and then given his neuro exam, there was concern for myasthenia gravis in him, and so these were his antibodies that were checked, both an acetylcholine receptor antibody as well as a muscle-specific kinase, and both were negative at that time. In terms of his echocardiogram, here, this was his admission echocardiogram. On the left side of your screen, you have an apical forward chamber, and on the right side, you have an apical two-chamber view. These images were both done with DEFINITY and were focused on the left ventricle. And so the ejection fraction in him was mildly reduced and estimated to be about 49%. There was also an area of focal wall thinning in the basal septum that you can kind of see here if you're able to see my mouse. That was of unclear significance. We're unsure if it was related to his reported history of MI back in 2001, or this is just an isolated diverticulum that we were seeing. Aside from that, there was no other significant abnormalities seen with his echocardiogram. So, given his clinical picture, as I mentioned, we had a high suspicion for ICI-associated myocarditis as well as myasthenia gravis when he came in, particularly given that his neuro exam was showing us right-sided ptosis and also muscle fatigability. So he was immediately started on a gram of IV methylprednisolone for a planned 5-day course. Neurology was also consulted and agreeing that his exam was concerning for myasthenia. I'll note that throughout his time, his respiratory status was kind of tenuous, and he continued to have some orthopnea and high-flow nasocannula requirements despite diuresis. And then given our concern of a neurotoxicity, a diaphragmatic ultrasound was obtained that showed bilateral diaphragmatic weakness that we thought was likely explaining his persistent hypoxic respiratory failure. Interestingly, his lab work, which again included these antibodies and an EMG, argued against myasthenia gravis, and instead neurology felt that his presentation was likely due to an ocular myositis and overall systemic myositis that was affecting his diaphragms too, and kind of explaining the weakness that we were seeing on his exam. And so for this, neurology recommended plasmapheresis for 5 days, as well as IVIG. So he got started on those, but despite steroids and escalation of treatment with plasmapheresis, he remained in complete heart block, so he ultimately had a transvenous pacemaker placed. While placing the transvenous pacemaker, we decided to do a right heart cath while we were at it to kind of assess his volume status and cardiac function, and the numbers are seen here on the screen. And his numbers overall suggest that he was euvolemic. He had a normal cardiac output index as well. And again, these kind of support that his respiratory failure is likely due to diaphragmatic weakness rather than overt heart failure. I'll note that he was on dopamine at this time for his heart block, and he had just received a session of plasmapheresis, which may be skewing some of these numbers. But overall, he was in a good state from a cardiac function. Ultimately, the patient received 5 days of IV Solu-Medrol followed by oral prednisone with a plan to taper it over 6 weeks. He received 5 sessions of plasmapheresis as well as 2 doses of IVIG afterwards. Despite receiving these high-dose steroids and plasmapheresis, again, he remained in complete heart block with a mildly elevated troponin throughout his course thus far. So the decision was made at that time to give him 2 doses of abatacept. Given that he was on plasmapheresis, the abatacept needed to be timed afterwards so that the pheresis wouldn't remove the drug from his body before it had a chance to kind of take effect. Ultimately, this didn't work in terms of reversing his AV nodal block. He remained in complete heart block. So a permanent pacemaker was placed that was complicated by atrial lead dislodgement and ultimately removal of the atrial lead. And he also had some acute renal injury that there was some thought may have been due to abatacept. He briefly required HD, but then was able to come off of it after a couple of days and was left with residual CKD afterwards. A biopsy was not done during our admission just because our clinical suspicion was high for myocarditis. And unfortunately, we weren't able to get an MRI while he was admitted because one, he was unable to lay flat for long enough to get an MRI, and then two, he had a fresh pacemaker that was placed. His follow-up echo had an overall stable EF of 50 to 55%, and he was discharged to SNF after 2 months for rehab. And this is a graph of his troponin trend during his hospitalization here. You can see that his peak was about 3.2, and that's when we started steroids. He also got started on plasmapheresis the subsequent day, and you can see that he had a nice response in terms of his troponin trend. After that, he had IVIG on day 5, followed by abatacept, and his troponin was nearly normal by the time he was discharged a couple of months later. And this was a CK response as well with treatment that showed a dramatic improvement after a day or two of treatment here. In terms of his outpatient follow-up, so he, from a cardiology perspective, remained in complete heart block and never regained function of his AV node. He was also noted to have a couple of episodes of NSVT on his device interrogation. From a hemonc perspective, treatment was held. He had a repeat scan that showed possible new liver lesions, and that his CA19N had increased to 7240 from 42 on this admission. And an MRI is still pending to kind of further work that up. And then interestingly, from a neurologic perspective, he continued to have double vision and developed some dysarthria. He was sent to a neuromuscular specialist who still had a high suspicion for myasthenia gravis, despite his prior negative workup. They tried some pyridostigmine on him, but he didn't tolerate it due to his GI side effects. And then they resent myasthenia labs at that time. His acetylcholine receptor antibodies and muscle-specific kinase receptor antibodies were still negative. However, they also sent a striated muscle antibody with this round of labs, and that turned out to be positive. And this antibody can be positive in about a third of cases of myasthenia gravis. So given this and their overall high suspicion for myasthenia, they decided to kind of treat him and restarted prednisone 10 milligrams daily at that time to see if that was going to have any effect on his symptoms. And that was recent, so I don't have any follow-up in terms of how he's done with that. So that was the case. Now I'll briefly kind of talk about the management of ICI-associated myocarditis and some of the data behind it. So in terms of management, the mainstay of treatment is steroids. The current recommendation is to start steroids early and at high dose, since both are associated with improved outcomes. Currently, the general recommendation is to start with 500 milligrams per gram of IV methylprednisolone for 3 to 5 days, followed by prolonged oral prednisone taper. Oral prednisone is dosed at about 1 milligram per kilogram and is usually tapered by 10 milligrams per week. And then throughout treatment, troponin should be used as a surrogate for treatment response, so that if the troponin rises, then this may be a sign that the myocarditis is not well controlled and that the dose of prednisone may need to be increased or tapered over a longer period of time. And the data supporting initiation of early and high dose steroids comes from an international multi-center registry of patients with ICI-associated myocarditis who received steroids for treatment. The study included 126 patients that were grouped based on initial steroid dose administered on the first day of treatment. And so the three groups that were included were low dose steroids, defined as less than 60 milligrams of sodium medrol per day, intermediate dose, defined as between 600 and 500 milligrams, and high dose steroids, defined as between 500 and 1,000 milligrams of sodium medrol. They were also grouped based on when the timing of their first dose of steroid was. So the groups that they included were with a dose within less than 24 hours, 24 to 72 hours, or greater than 72 hours after they were admitted. And what the study showed was that there was an inverse relationship between the initial dose of steroids and the occurrence of MACE. And as you can see in the first figure, low dose and intermediate dose steroids were associated with a higher risk of MACE compared to high dose steroids, which is there in the blue line on the left. Additionally, patients receiving steroids within 24 hours of admission also had a lower rate of MACE than those receiving steroids between 24 and 72 hours, and those receiving steroids after 72 hours. And this is illustrated in the figure on the right with the blue line on the top representing the group of patients who received steroids within 24 hours and had better outcomes compared to the other two groups. Although both the dose and the timing of steroids play important roles in mitigating adverse outcomes in these patients, it does appear that the initiation time of steroids may play a stronger role between the two. The same study showed that the use of high-dose steroids did not overcome the detrimental effect of initiating treatment later. As shown in this figure, patients who received low-dose steroids within 24 hours, which is shown here in the blue dotted line at the top, had better outcomes as compared to patients who received high-dose steroids after 72 hours, which is shown in the red solid line in the middle of the graph there. So this again supports the importance of having a high suspicion for ICI myocarditis and starting steroids as early as possible. And recently, ESC released cardio-oncology guidelines supporting initiation of high-dose steroids, which we've been chatting about. And this is a figure that provides a framework with how to treat a patient that presents to you with myocarditis. So the first step is to discontinue the immune checkpoint inhibitor in all these patients and admit them to the hospital with continuous ECG monitoring. They then recommend initiation of high-dose salmeterol for 3 to 5 days. From there, the decision on the next steps depends on the patient's overall clinical picture. So if the patient is recovering and responded to treatments, you can transition to an oral prednisone taper with a starting dose again of 1 milligram per kilogram per day and troponin monitoring throughout the taper. If the patient is not improving with steroids, then second-line immunosuppressants should be considered. And then lastly, if a patient is hemodynamically unstable with fulminant myocarditis, an escalation of immunosuppression is recommended and use of advanced mechanical support if needed. So what are the second-line immunosuppressants and when should you consider a patient to be steroid refractory? So per the ESC guidelines, a patient is considered to be steroid responsive if the troponin improves by 50%, if the patient's AV block arrhythmias improve, or if the LV inflection improves, all within 24 to 72 hours. If this is not the case, then this is when they recommend considering the addition of a second immunosuppressant for treatment. And common immunosuppressants that are used as second-line agents include abatacept, IVIG, mycophenolate, infliximab, and plasmapheresis, and ATG. But data is very limited for these agents, and their effectiveness in ICI-associated myocarditis is unclear. There are only a few scattered case reports documenting their use for myocarditis, and the rationale for the use is usually extrapolated from data gathered from other immune-related adverse events. So for example, infliximab has been shown to help with ICI-induced colitis. However, that's something that we need to be careful with, as it's also shown to worsen heart failure in some of these patients. Additionally, because myocarditis is usually occurring with other immune-related adverse events, you may end up using some of these additional agents regardless, and it makes your decision of which to use a little bit easier. So for example, plasmapheresis and IVIG are helpful for neuro-related, immune-related adverse events, such as myositis and myasthenia gravis, and both were used for the case I was presented in this case. So one of the agents that has started to get more attention is abatacept. And abatacept has been used for rheumatoid arthritis, and there has been case reports that was showing varying degrees of efficacy for steroid refractory ICI myocarditis as shown here. Abatacept inhibits upstream antigen presenting cells and thus presents T cell stimulation. It's also believed to have limited off-target effects and believed to be reversing the activated pathways that are involved in immune checkpoint inhibitors. There have also been animal studies that have shown that the administration of abatacept leads to a reduction in cardiac immune activation and an increase in survival, but human data is limited thus far. I'll point out that there is currently a clinical trial in process called Atrium, which stands for abatacept immune checkpoint inhibitor myocarditis, which aims to see if abatacept administered concurrently with steroids reduces adverse cardiac events in these patients. So once we have treated the myocarditis, what do we do with the immune checkpoint inhibitor afterwards? Unfortunately, there is limited data with regards to re-challenging a patient with an ICI if they have developed myocarditis. It's also unclear if challenging with a different class of an immune checkpoint inhibitor changes their risk. Most would agree that if a patient had a severe adverse event, that the immune checkpoint inhibitor should be held indefinitely. But there are some studies with non-cardiac immune-related adverse events where re-challenging with the medication did not necessarily result in recurrence of the toxicity. Additionally, if the patient developed myocarditis on dual therapy, re-challenging with a single agent can also be considered, since dual therapy tends to increase the risk of developing the toxicity. Ultimately, though, the decision should be made based on the severity and the nature of the initial event, how they responded to treatment, and accordingly, what the availability of alternative treatment options are for their cancer. So overall take-home points are to maintain a high clinical suspicion for ICI myocarditis, especially if they're presenting with other toxicities such as myositis or myasthenia gravis in this case. High-dose steroids should be started as soon as possible. And if the patient is not clinically responding to steroids within 24 to 72 hours, then additional immunosuppression should be considered. And then lastly, you should consider transferring the patient for a higher level of care if your site that you work at doesn't have access to these treatment agents that were discussed, or mechanical circulatory support is needed. But that's my talk. Thank you again all for listening, and I'll turn it over to the panel.
That's an amazing talk, Celso. Thank you so much for your presentation. I wanted to actually jump into a couple of the questions that were in the chat box, a couple of really great questions that we were leaving here towards the end. I kind of want to, this is target both to you, Deb, and to Eric. I mean, Deb, you guys are seeing a lot more, patients with either, any of the ICIs really. And the question was really, is there any utility for kind of serially getting high sensitivity troponins in these patients, and if you do it, what it was based upon their cycling, et cetera. And then, Eric, if you have any additional information or insights as to just the cardiac biomarkers overall as well, BNP, et cetera, in this would be useful.
Yeah, I think it's really challenging. I think, in terms of pre-treatment labs, we'll do kind of your basic blood work to look at the transaminases and the creatinine and things like that, and thyroid, because about a third of patients will develop thyroid dysfunction. But in terms of these rare immune-related adverse events, we have not routinely implemented kind of screening across the board outside of a clinical trial. But it's certainly worth a discussion as to how we should incorporate, as we're discussing something that is potentially rapidly fatal and requires a high index of suspicion.
Yeah, I over-agree with Deb. I think, I'm on the spectrum of testing. I don't know, I would regard myself a little bit more on the conservative side because, again, it's a fascinating, syndrome, but at the same time, we know that the absolute number of cases will probably go up since, again, to the core reason why we're even having a webinar on this, over 40% of the US cancer population may qualify for immunotherapy, like first line, second line. We're not even talking about the clinical trials, right? So I think for cardiologists, it's important to be aware of this. And I frankly think it will take over as, it will probably overtake, giant cell myocarditis or some of the other dramatic viral cases we see as really the predominant form that needs to be watched for. In terms of biomarker screening, I think, I probably would agree, one of the big premier gurus on immune checkpoint inhibitors, Tom Nealon at MGH, and he's also the PI of the Atrium trial. I think a baseline screening troponin biomarker would be adequate before starting treatment. And it's really not so much to look for a problem, it's just to get a baseline. A troponin elevation is frankly just a marker of myocardial damage. We all know this as cardiologists, right? But I think the thing is that if you get another troponin in the midst of some kind of, complication, toxicity, an elevated biomarker without a pre-existing one, it's very difficult to make heads or tails what to make of it. And high sensitivity is unfortunately even more sensitive, that's why it's called that, in causing more concern or consternation without a baseline. So I think if anything, if I had control of a patient about to undergo immune checkpoint inhibitor therapy, I think a baseline troponin assay of whatever your choice is as a baseline would be adequate, and then move from there, and a baseline echo. And I think, again, because there can be some clinical manifestations, again, this is my personal opinion, I don't have a lot of strong data to back this up, but yearly echocardiography is reasonable to check since we have many patients, let's say with metastatic melanoma and other lung cancer disease states who have been on immune checkpoint inhibitor therapy for years. It's not a bad idea to kind of intermittently screen for subclinical issues so you can track issues. They have studied a biomarker-based strategy. I think Stanford did it. And there was also a study that came out of Korea recently, and Sloan Kettering also did a troponin immune checkpoint inhibitor based strategy just to see like how often, troponin assays went up. And, I don't have the exact numbers, but they overall all found that the yield of diagnosing actual myocarditis from biomarker elevations with each treatment was actually really low. But on the flip side, what else do you get? You end up getting a lot of consternation and concern, both hemonc and cardiology, going, oh my God, this is myocarditis, we have to get these stat imaging biopsies, and some of these studies actually went so far as to do that. And they found that the yield of actual clinical myocarditis was really low. So I think, although the 2022 guidelines suggest that, and I'll be honest with you, it's expert opinion, I don't personally agree with that approach unless it's someone you deem to be very, very high risk. I can only think of one instance where you would check troponins before each one. It's because it's someone who survived immune checkpoint inhibitor myocarditis and they know there's no other option and they're willing to get re-challenged. That's when I probably would get on, troponins with each assay. We had plenty of anecdotes to share, but I will just really quickly just share one case of a gentleman who had stage 4 squamous cell that was basically eating off half his face. And he went into heart block after Supilumab was given first dose with paroxysmal VF. He got a pacemaker. His oncologist emailed me and said, on a scale of 1 to 10, how bad of an idea do you think it is to re-challenge him? I said, probably an 8 out of 10. He says, yeah, but he's going to live 6 more months if we don't do anything. So I said, okay, well, as long as he understands that, that's fine. So we agreed to proceed. So it's been a year later. He's actually in remission, and he's still getting immunotherapy, and he has a pacemaker that's telling him he has AFib. So that's really the most, so again, these disease states, really, we have no idea what can come of it. And we're completely always re-humbled by, what they can tell us, or what we think, when we think we know we have a handle on it, they completely throw us for a loop again. So those are my thoughts regarding sort of biomarker screening and tracking as well. So.
Thank you. These are great comments. Another follow-up question in the chat box from the audience, same audience member actually, is also if suspicion for ICI myocarditis is high, do we need to wait on the results of the endomyocardial biopsy before initiating steroids? What are your thoughts on that?
So to me, I think it's still a clinical suspicion. I think there's two layers of complexity to that question. One, right, if someone comes in already with those markers of, multi-organ involvement, biomarker elevation, which I think is probably one of those specific things. It's important to understand too that 50% of patients will have a normal ejection fraction. So an EF by itself is not reassuring. With all that and those conduction abnormalities, that's pretty high risk. I know there's obviously concern about cancer prognosis, about putting someone through steroid therapy, but usually that requires, I think, a biopsy would be ideal if the MRI is, most people would prefer to go through a non-invasive route first, do the MRI first, but we know that's not 100% sensitive either. But if that's positive and shows signs of myocarditis, you can stop right there. But if you don't have access to an MRI and it's really going to make a difference about treatment or whether the patient can get re-challenged and you're not sure, then I think a biopsy is very reasonable. The second layer to that complexity is not every hospital has access to either cardiac MRI or endomyocardial biopsy. So then that comes a question of saying, well, again, if you have someone who may be getting sick, it might be going the wrong direction, regardless of their cancer stage or prognosis. Do they need to go to a center where that needs to be done? And I think that's also another important teaching point, is that it's important to always talk to your cardiomyopathy or heart failure specialists or cardio-oncology specialists, decide, well, when is it time to pull a trigger to get them somewhere where that can happen? The second case that's also presented was a result of systems of care, because the oncologist who took care of that patient called me and said, hey, I'm sending a guy of mine with cholangio has a positive troponin and is bradycardic. So those are two red flags that just already pop up with the guy who's getting immune checkpoint inhibitor therapy. So we were able to find his record in the ER at one of our UCLA hospitals, call the ER attending, get our heart cardiologist to go lay his eyes on him. They see him and say, this looks bad, transfer him over to our CCU, So there's levels where you can try, you have to kind of know when you need to get them to somewhere in case things really go downhill, or you need to escalate therapy, or you need, the ability to get, because at that other hospital, we didn't have immediate access to MRI or endomyocardial biopsy. So that's another layer of complexity, that if your suspicion is high, think about putting them somewhere where they can get those things as well. So in case that needs to happen. So.
That's really great insight. Thanks, Eric. And then the last question from the audience, but I think it's a great question, and it's already been touched upon a little bit with respect to the re-challenging of ICI therapy. But if the myocarditis or ICI myocarditis was more mild, and a re-challenge, based upon discussion with oncology, cardio-oncology is really felt to be the best thing for the patient from an oncologic standpoint. Any suggestions about leaving on steroid therapy, going through the treatment with the re-challenge of the ICI?
I kind of want to ask Deb about that question, how she would feel about that. Because it's tough, it's not good for, from a cancer treatment standpoint. It's always, I personally think it's a personalized, customized decision on what the best way to go about it is. But,
yeah, so I think that's a really, really great question. Early on, we certainly excluded and we still do, in the context of clinical trials, we exclude anyone from participation if they're requiring anything more than the equivalent of prednisone 10 milligrams daily systemically. I think in practice, the idea that immune suppression can kind of counteract any effect of immune checkpoint inhibition on the cancer has not really been borne out in a systematic way. So I do think it's a case by case. I think in an ideal world, we would try to wean off immune suppression and keep it off or as low as possible before resuming the checkpoint inhibitors. But I certainly do have patients outside, that I treat clinically who, for their arthralgias or what have you, require a little bit of steroids on board or a little bit of immune suppression or immunomodulatory agents. And we continue the immune checkpoint inhibitors and they do okay, kind of balancing everything. But it is a kind of a case-by-case discussion. It does require kind of close interaction, multidisciplinary follow-up and communication. So I definitely would not take that off the table.
Yeah, I mean, the guidelines also, in talking to a lot of experts having dealt with myocarditis, they actually want to be very aggressive in tapering down, prednisone. Like once you transition to oral, we usually try to go for 10 mgs a week down. And usually I check outpatient troponin biomarkers and make sure there's no rebound, especially after, encountering Jacqueline's case. You just don't know, when the brakes could come back off and there could be issues again because we just don't know enough about that, and sometimes if there's other reasons to be on longer steroid therapy, like severe myositis and other things, sometimes I know a rheumatologist will take control of that as well. And you just have to have a conversation with them about, well, like, how long do you think this needs to happen or go on for? So yeah, there's no cookbook way, because there's equipoise with all the treatments, and that's why trials such as Atrium, full disclosure, will be the site PI for UCLA. We're trying to understand which treatments may actually be better in such a a much more I think a growing phenomenon of what we're going to be seeing in the cancer population.
Great. Well, I know we're a little bit over, so I appreciate the audience members that were able to stick around a little bit late. Just want to thank our amazing presenters, Dr. Wang and Dr. Diaz, and our esteemed expert panelists, Dr. Wang, Dr. Yang. Thank you all so much for being here, all the audience for being here, and everyone that ends up reviewing this webinar down the line online that weren't able to make it tonight. Thank you for watching, and stay tuned for additional California ACC cardio-oncology web rounds in the future. Plan for the next one probably in the next 3 to 4 months, and Stanford University will be hosting. So again, thank you all, and have a great night.
Thank you.
Thank you so much. Thank you. Deb, thanks so much for